Public health is a population-based field of science focused on preventing disease and promoting health. Every week, we will be engaging in interactive discussions and analyses of the latest public health issues affecting you and your communities all around the world. This is the Public Health Insight Podcast.
My name is Linda, and I'm here with Gordon, Ben, Will, and Sully.
Before we move on, it is important to note that the views expressed in this podcast are our own and do not represent any of the organizations we work for or are affiliated with.
Trigger warning. Please note that this episode will discuss suicide and may contain sensitive or triggering content. If you or someone you love has been impacted by suicide, you are not alone. Please use your discretion when listening and connect to supports as needed. For our listeners in Canada, Crisis Services Canada offers a national suicide prevention hotline, which can be reached at 1-833-456-4566 or by text at 45645. In our previous episode, we looked at the global impact of suicide, the risk and protective factors involved, and how COVID has impacted suicide and mental health. Today, we're going to talk about suicide prevention models, their strengths and limitations, and some strategies moving forward on how to invest in a more holistic model of prevention as opposed to an individual level.
Prevention, it won't be so doom and gloom as the last one where we just talked about it. So looking forward to talk about resiliency and hope building.
Mm-hmm. So according to LivingWorks, I found the statistics and I thought it was really interesting. Mm-hmm. It says that we're more likely to come in contact with someone in need of suicide intervention than we are to come in contact with someone in need of CPR. So if we just think about that, how often have you had to do a CPR training course? It's mandatory for almost all types of service professions.
Right.
And, CPR is something that you're taught since you're a kid. But with that same energy, do we apply that to suicide prevention? If we are even more likely to come in contact with someone in need of intervention for suicide. What do you guys think? Is prevention something that has as much exposure as it should? Or is suicide even preventable to begin with?
That's a tough one, Linda. That's the CPR is literally on pretty much every job description because it's so valuable, right? This is a lot of times when we compare stuff, it's not to minimize the more common thing. It's just to say, why is the other thing not as highlighted, right? So it's not that we're minimizing, hey, you shouldn't do CPR as much because suicide intervention may be more of a valuable skill. We're saying that both are very important. So I know from my experience being involved with suicide prevention in the workplace, we know that 70% of all suicide-related deaths, particularly in Canada, occur in those working age populations. So when we're on the subject of CPR skills at work, we should absolutely be talking about suicide prevention at work. So there is definitely a value there. And in terms of policymakers and decision makers like to look at, cost savings, and we don't really, a human life is priceless, but we'll try to put it in economic terms. In Canada, there's about $6 billion lost due to poor mental health and suicide loss in the workplace. So there's absolutely a business case for organizations and workplaces to implement formal suicide prevention training for their employees, for sure.
That being said, though, I do want to acknowledge that whether it's progress in society or even just in the field of employment or just whatever in general, I do acknowledge that the topic of mental illnesses and suicide and just talking about that, it is definitely improving, and I think there's more of an environment to at least welcome it. And I think obviously there's a lot more work that needs to be done if we want to reach optimal levels. But I do want to acknowledge that I think let's even just comparing it to 5-10 years ago, talking about mental illnesses, talking about anxiety, stress, and all these just psychological aspects of health. I think there's definitely a room for that in the workplace, and at least in my work. So at the federal level, we have the employment. It's called the EAP program, where it's I think employee assistance program, something like along those lines, where it's a service available for any individual who might feel that they need access to the services.
Mhm.
And I think, that's definitely some progress that's being made.
Yeah,
Right.
that's for sure, because there are, even if you think of just, when people buy into their employee health benefits, right? A lot of, you know about dental and pharmacy. Now a lot of things are being included for counseling services and stuff like that. So there is progress made. But I will caution though, those smaller kind of businesses and workplaces don't have access a lot of times to those resources. So people working in those types of environments are less likely to be able to access those supports. So there is some kind of like a gap there between the bigger organizations and corporations and the smaller businesses that we need to address.
And we could talk about this later on, but I guess a more holistic form of prevention would be to advocate for everyone, all businesses, to be able to afford those types of services for their employees. We could get into it later. I can rant all day, you guys, but for now, let's bring it back a little bit. So the World Health Organization came out with a report that said that the majority of suicides are in fact preventable. And I guess in the past, there's been this mentality that, suicide is an unfortunate and an inevitable outcome. And it is unfortunate. It's devastating. It's a difficult outcome to happen to anybody and people close to them. But the interesting piece is that the majority of suicides are preventable. And so if we look at suicide prevention in general, what prevention models look like, I just want to highlight 3 aspects of prevention in case we may not be familiar with them, or if this is a new area, or if we're just curious. So when we look at prevention for suicide, there's universal, selective, and indicated interventions. So when we talk about universal prevention, these are types of measures that are available to everyone. And so this could be something like a media campaign, or even things like, Bell Let's Talk on social media, or crisis lines, or even things like giving financial benefits in a time of crisis. Like these are universal because they target everybody at a more upstream level. Then when we go into more selective measures, those are things like training programs or screening and assessment programs. And they're selective because they're only for a particular subset of the population. And then lastly, for indicated, these are for people who are showing warning signs or who are at more of a higher risk. So that could include things like inpatient programs. And overall, they just differ in who is being targeted.
And I'm assuming that ideally, when targeting prevention, you would want to tackle all 3 levels, right? And because, like we discussed in our previous episode, the topic of suicide is very nuanced and multi-sectoral, multifactorial. It covers all of society. It's a global issue. So I think optimally, it would make sense that you would want to kind of approach and find ways to tackle this issue from just different angles. So, and I wanted to ask, so in the universal category, would something like World Mental Health Day, would that be placed in there, or would that fit in?
Well, from my understanding, things like social media campaigns are universal because they target everyone. And so something like World Suicide Prevention Day, for example, which is September 10th, by the way, mark your calendars. I think that would be universal.
Yeah, universal.
I don't know. What do you guys think?
Yeah, universal, because the key thing with the so universal, selective, and indicated, universal is not targeting specifically people who are experiencing thoughts of suicide or who have been bereaved or have lived the experience of suicide. It's targeting people who don't have any of those, but to raise awareness of the issue so that they can kind of join the cause. So that is more of a blanket approach, something like raising awareness for sure. And then you have the selective one where, I referenced the workplace example. Maybe you have health and safety reps, right? So maybe those are some skills that you'd want them to have to be able to intervene if a coworker is experiencing thoughts of suicide. So you see it as you go down the ladder, it gets more targeted to the intended audience of it.
But and my issue though with suicide prevention models, firstly, we need them and they are great, but I think they can be improved in the sense that so far what I've often seen are things like, telling people to recognize warning signs, ask people, connect them to resources, access therapy services, take a training course. And these are all focused more so on selective and indicated, more individual measures, which are good and needed, but they're so far downstream.
So are you saying that we need more universal to tackle like the whole stigma behind suicide?
Absolutely. More upstream, like what is the cause of this? The causes of the causes. Why does someone feel that suicide is the only response to a problem? What caused the problem? And so while not eliminating the other measures, I feel that we are lacking in that more upstream intervention.
Yeah, that also reminds me of there's a model called Zero Suicide, and it's a comprehensive approach to suicide prevention to be applied across health systems. So it started in the Henry Ford Health System, and it was conceived because they were finding that up to 80% of people who later died by suicide was attended to by someone in healthcare in the previous year. So there's an indication there that things were missed, like we talked about warning signs, maybe the proper follow-ups weren't in place. So this model was developed to engage in quality improvement in the healthcare system to be able to better support the needs of people experiencing negative mental health outcomes, because we know healthcare is more acute, focused on stuff, right? So the problem with that model, though, is most people who are experiencing mental health or thinking about suicide do not go out and seek help from the healthcare system. So if we focus only on healthcare system interventions, there's a huge bucket of people that we're not able to catch because they don't go. That's not the first place they go to get help.
Yeah, that's definitely problematic because it doesn't address what Linda was saying earlier with this tackling the stigma and at the universal level. And to be honest, I feel that realistically one of the ways to really respond to the stigma and address it is to normalize talking about mental health and mental illnesses and suicide on a societal level. I don't know the specific strategies that will be required. And if I did, that would be awesome. But I think it's one of those things where if you can get people talking about it, and making it, something that's normal and that's okay to talk about, that's a pretty big step forward, I think.
So pulling on, Will, what you've just said, and Gordon, what you mentioned about not solely focusing on the health system to respond to suicide, it sounds to me like we're talking a lot about expanding suicide prevention. So to include other sectors, to be like a whole of community approach. And so I want to bring in more of a paradigm shift, this model called the socio-ecological model of prevention. This is a foundational concept, I guess, in public health. And so it's a framework that can be applied to so many different public health issues. But essentially, it describes 4 layers of how to think about an issue. And in those 4 layers, you can apply different strategies to respond to it. So different prevention strategies. And so the one that I'm looking at or thinking of is from the CDC, the Center for Disease Control. And the 4 levels of it are individual, relationship, community, and societal. And at the individual level, that refers to just biological and personal factors that can increase risk. And so on the flip side, prevention would be influencing attitudes, behavior, and beliefs. And I think a lot of prevention strategies focus here at that individual level.
Relationship / interpersonal looks at how people interact with their more immediate social circles, and prevention efforts include galvanizing and looking at these immediate social support networks in order to best support the person. And things like that include parenting programs, mentors, or peer supports are a good way as well.
Mhm.
Yeah.
And with community, it goes towards looking at a person's interaction with like schools, workplace, neighborhoods, or wider social relationships. And what prevention looks like in that atmosphere is modifying your physical or built environment and policies associated with the community.
Then we have societal, which includes the broad social factors and all the cultural norms we're experiencing. And in this regards, the prevention includes advocating for policies to reduce social inequities. And what makes this model different from all the other models is the community and societal aspects of it. We're simply looking at a more upstream level, more broader, more holistic approach when tackling
Causes of
suicide
the
prevention.
causes.
Causes of the causes. All this comes back to that.
Just for our listeners at home, we'll be providing some links to the resources if anyone's interested in diving a bit deeper into this framework.
Mm-hmm. So even going back to those risk factors we talked about last episode, things like age or ethnicity and race, some Indigenous communities have higher rates of suicide than the general population. Mm-hmm. And if we only focus on that individual level of prevention, it's not enough. It's not adequate. If we forget or ignore those societal and social aspects that influence suicide, like racism, like trauma, like oppression, like the effects of having your land colonized, those are very real and pressing factors that influence suicide. And so we need to expand the way we consider suicide prevention.
Right. If we individualize it too much, we miss seeing those trends at the population level, and that might require kind of a more holistic intervention.
We end up just kind of pathologizing an individual. Again, like all the others, social determinants we've talked about, it's not in isolation, right? So
right. And then to your point too, like when you do see, when it emerges that certain populations disproportionately experience suicide, so that's okay, that's good to know, but then how do we leverage those existing strengths to build resiliency and coping skills in that population in a way that's culturally appropriate to them, right? So it's not a one size fits all. There are certain best practices that can be scaled across different settings, but you also have to bring in the community to own and to contribute to those interventions that are going to be adopted.
Yes.
So.
I think also you have to make the individuals or the organizations that started those racist policies accountable. For example, if we have intergenerational trauma with some Indigenous communities due to residential schools or other racist policies, then, there has to be government acknowledgement to even open up that conversation. Yeah. Right?
For healing.
Yeah, exactly.
And I really like Gordon's point about, that solutions cannot be one size fit all solutions. And, bringing in, especially in the context of Indigenous communities, bringing in traditional knowledge, traditional expertise and cultural practices and cultural strategies and just things like that, which, in combination with a lot of these other strategies that we've been talking about.
Yeah, absolutely. So we've kind of touched on this in terms of what expanding suicide prevention could look like. Does anyone have any ideas of what increased efforts at community and societal levels of prevention could look like? I know, Gordon, you had mentioned having...
Call out.
prevention
I don't know
strategies.
what you're going to say, but I'm ready.
Prevention strategies in place in the workplace. So that's a more community level. So occupational prevention strategies. Does anyone have any other ideas? Or would you like to expand on that idea?
Well, yeah, I think if you even go up to, in this context, societal or community-based strategies, that there's a theme throughout this episode that things have to be multi-pronged because there are multiple risk factors that need to be addressed, right? So I wanted to touch on, there are a lot of community-based suicide prevention models being adopted in communities across the world. But in our very own Canada, recently, the Mental Health Commission of Canada implemented the Roots of Hope community-based suicide prevention program. And basically, this is founded on 5 pillars of prevention. So The first pillar is specialized supports, which deals with the prevention and crisis side, and the peer supports that we touched on, as well as workplace interventions and the training and networks. So healthcare providers are very important in this discussion because they need to provide a safe space for anyone that is going through the healthcare system to ensure that they're not stigmatized, and to build that trust, to know that as a patient, your healthcare provider will have your back for such a stigmatized issue. So that's a very important aspect of as well. And when you think of even upstream, more universal, public awareness campaigns are very important to raise awareness of issues. And we talked about how suicide is considered a silent issue because of the stigma associated with it. The second to last component of the 5 pillars is means safety. And this touches on basically ensuring that some of those commonly used tools that people use to die by suicide, whether it's medications or guns or other weapons, are not easily available. So things like if you have medications in the home, if you're a parent, you're on opioids, making sure you have a cabinet that you can lock stuff up. So it's not that this will prevent whoever's thinking about suicide completely from dying by suicide. It just makes it a little bit harder to access those commonly used things that are used to do so. And lastly, research, setting priorities, looking at the situation in communities, understanding that communities are different, and then you have to have an evidence-informed approach to address suicide in specific communities. So these are just some key aspects of a societal or community-led suicide prevention model that takes into account all the strengths that you can leverage to have a suicide-safer community.
That's a great point, Gordon. And I wanted to highlight a case where we had an intervention that was societal, but then we were able to change it or have a consideration for also a community level intervention. So there's something in Ontario called the Mental Health Act. So basically what the Mental Health Act does, it regulates the administration of mental health care. But the main purpose of the law is to regulate the involuntary admission of people into a psychiatric hospital. So let's say if you have suicidal ideations and you go in to see a healthcare provider, the healthcare provider could force you to go to a psychiatric hospital for assessment if they believe that you're a harm to yourself or others. Now, obviously, this could be a very traumatic experience because your rights are being violated. You're put in isolation. You're not given treatment there, mind you. You're only given the assessment. So there's a lot of stigmatization where an individual doesn't want to go with this option, obviously. And they might not reveal their suicidal ideations to the healthcare provider due to this fact. So it doesn't really help, for example.
Right.
Now, an amendment to this act was created where a physician who makes the decision for the assessment could actually do a community treatment order. So what the community treatment order does, it goes to that next level of the framework where an agreement is brought in by the patient, by the physician, other healthcare providers such as social workers, the family as well. And the person isn't put into a psychiatric facility, but they're actually living at home and they have these resources and facilities brought to that person. So I think that's a good highlight of how we work within both realms of this framework, aka community and social, and how we've also been learning as we go on with these interventions and modifying them to what is more applicable or what is more beneficial. Because oftentimes we try to do good, but the very legislation that we pass might cause more harm.
Right. And listening to people say like, this is harmful. I don't want to be forced to go to a facility. I want to have care in my own community. Yeah.
And just to think of just how stigmatizing it would be to be in a psychiatric facility, like how you might be worried about your friends or family labeling you with like disparaging terms, right? So you can understand why the healthcare system just needs to be a safer place for people to even express those things in general.
And another thing of that is that it's going to be on your record for all your medical records in the future. Like, for example, if you go in for another unrelated issue, and if a physician sees or a healthcare provider sees your medical records, they see that you were formed, that brings its own biases in within the stigma of healthcare or society in general. So now you're being treated differently for something where you tried to seek out help.
Right.
Like, it's
Great point.
It's a downward spiral.
We talk about stigma so much just in the general society, but there's also stigma within the medical field too.
Exactly, the place where you think you'd be getting the help from, right? So
Yeah.
We're all part of the same society. What can we do?
Great point.
I want to bring up a critical point about, say, the socio-ecological model. Because when we tackle, say, the issue at the community level, at the societal level, and then it's like, okay, we're trying to prevent the stigma, but do you guys feel like we should go even more upstream than that to eliminate people even thinking about suicide because of all the socio and cultural issues around them,
absolutely.
and problems of equity, problems of racism, problems of all that? If
We need a radical overhaul of society.
that's exactly what I'm trying to get at. Yep. Like,
I agree with
it's
you.
so easy to say, so hard to execute, I guess.
Because it's so hard to affect that larger scale social change, we concentrate efforts on the more individual, interpersonal, community level, because it's difficult to have that overarching change. But you're right, we do need to think upstream as well.
One thing I wanted to, not to bash on upstream, just to play a little bit of devil's advocate. A lot of times, right, you can have, policy is considered one of the most upstream actions you can take. But a lot of times the infrastructure doesn't exist to execute the policy effectively, right? So by just focusing on policy and missing out. So if we have a policy that communities must provide certain things and the communities aren't giving the resources to execute the policy, then the policy falls flat, which a lot of times happens for a lot of policies. And Ben talked about, a lot of times we implement a policy and we don't get the intended effect, whether it's no effect or a negative effect. So we can't get too focused on a rabbit hole of only upstream without missing boots on the ground, engaging passionate people on issues and things like that. So I just wanted to make sure
it's not one without the other. For
right.
Sure.
We have to make sure that those are being done at the same time.
So in tying all of these points together, we recognize that prevention needs to occur at different levels of society. There needs to be follow through, and we need to work on addressing stigma. But I guess what I'm hearing is that we get stuck on how to do this. How can you coordinate, a widespread intervention at different levels of society? And so I want to bring up a proposed action plan, a proposed method of action called the National Suicide Prevention Action Plan. And this is something that the WHO has recommended for every member state to implement. And this is a desirable thing because it's an initiative that is led by government. And because it's led by government, the government is able to firstly prioritize suicide prevention as part of their agenda. They can provide that leadership and that guidance, as well as bring together people from multiple sectors, from healthcare, from education, from infrastructure, from different aspects of society, bring those people together, and then develop a strategy together. Also, in best case scenarios, governments have access to surveillance data. They can provide and disseminate that data. They can provide funding. And so to note that not every government is capable yet of doing this, but I think this could be a method of having a more holistic prevention plan.
Yeah, as I think my initial reaction to this is, as with all WHO, global action plans, it does seem to be, very idealistic.
For sure.
And it's important when looking at policies that, policy and I guess the political situation of countries go hand in hand, right? And,
Sure.
WHO can be recommending something for a country, but if that country, whichever government or party or what individual in some cases even is leading that country, and if this isn't part of their agenda, then there isn't much that can be done. So I think, you know, it's one of those things where I think just for the sake of multilateralism, it's a good thing, and it's good to see that you know, the global community and, you know, just global public health forum is taking suicide prevention and as a very important issue. But it's the actual level at which it gets implemented. It's we'll have to see about that one. And that very it's a very, I guess, cynical way of looking at it, but I think I think it deserves, you know, this view for sure.
Not necessarily it will, because in the same reading, right, like we talked about how low and middle income countries have about 79 or 80% of the population in the world that died by suicide, but yet they are slower to adopt these national suicide prevention measures, right? So the countries that are affected more are the ones that are not even taking or adopting these national suicide prevention measures. So there's literally evidence for what you said, because we need to ensure, and that's another thing I was bringing up too, like when you come up with these, and I know their intentions are good, but when you have these blanket kind of recommendations and some countries, like you said, don't have the resources to execute it, it becomes very problematic.
And it's not even just the resources, it's that if they don't have, you know, like the political backing to do it.
Right.
And
priorities and the wills.
But this is where that having that awareness, even as a citizen, is important, because you can hold your elected officials accountable.
Exactly.
Yes, you know, we can knock on low middle income countries in the sense that this may not be the highest priority because there are other things to deal with, which is true and valid. But look at Canada. We don't have a national suicide prevention action plan in Canada. And it's noted by the WHO that Canada doesn't have one. I mean, we have a framework, but we haven't moved yet to an action plan. But what is our excuse? And I think that as a country that, you know, we claim to be a leader in so many things, and we are, but we can do better. And so, you know, for us as the public, we can hold our elected officials accountable too.
So do we know that if countries with a national suicide prevention action plan are more successful at reducing suicides than countries without? Because if it's just a title, then, and there's no kind of positive outcome measure, which brings you to Sweden, which you're going to say right now.
Right. Well, even just to respond to your question, though, like this was only proposed in 2014 for all member states. So there hasn't been like a concrete evaluation of which countries have it, which don't, what are their rates of suicide.
Yeah. And as I mentioned earlier, it's, you know, things like WHO you know, action plans that they have that they agree on. Oftentimes, you know, it's as much as, you know, the WHO attempts to not be a political forum and tries to be a very technical setting, you know, the politics that countries engage in, you know, just the political diplomatic dimensions is deeply rooted in the organization. So like, you know, even if you have all member states, you know, hypothetically, and I got air quotes here, you know, agreeing and, you know, adopting this, I feel like oftentimes it's mostly just for optics sake and to look like that. You don't want to kind of be that one member state who's left out. Yeah, exactly. Yeah. Right. It's like you want to kind of sign in and like join the crew, join the party, but realistically, it's I don't know.
But if you know that your country has an action plan and you see they're not doing anything about it, like it's just better than nothing. It's better than just sitting there and saying our country should do something, but we're not doing anything.
Yeah.
Yeah, it's the politics of it, right?
Anyway, just as an example, though, you may remember from our road traffic episode, we talked about Vision Zero before in reference to reducing road traffic injuries. And Sweden was a leader in this area. And when it comes to suicide prevention, they also have Vision Zero for suicide prevention there too. And it is a national prevention policy that was introduced in 2015. So it has been effective, but financial support has been nowhere near what was given to road traffic safety. So there's that discrepancy there, right? It could be on the agenda, but how much priority, how much funding is given to it? So I know we've spoken a lot about, you know, statistics and numbers and things like that, but often what gets missed when we talk about suicide are that it's actual people, communities, and families that are impacted. It's it's you and me and like our neighbors and listeners. And so I thought it'd be nice to kind of just wrap up with sharing either experiences with suicide prevention, either in the workplace or at a personal level, if we would like to share.
Yeah, so I can definitely start. So just a bit of context. So I am I'm of East Asian descent. I'm Chinese, and I think the issue and just the topic of suicide prevention it's such a important topic that I find is a very muted and taboo discussion, at least in my community. And whether it's due to the cultural roots, or it's because of other factors, I find that especially when trying to have this sort of discussions with let's say, for example, people in previous generations or older individuals who might not have been exposed to talking about this as freely as we have. It's important to here I am going back to the idea of messaging and communication again, is to find ways to integrate the cultural aspect in the communication, right? So if you are trying to talk about suicide prevention, you can't be approaching it only from a North American Western lens, but finding ways to integrate the traditional knowledge, traditional cultural components as well. It's even just simple things like translating materials so that it is available in other languages, I think would help a lot of newer immigrants who might be right in that vulnerable population that we discussed earlier about who are at risk of attempting to end their life. And I feel like it's one of those things is getting more traction. Things like translating important documents, translating information. We've seen it with COVID, we've seen it with other issues, but I wonder if that's being done with suicide prevention. If not, I wonder why not.
That's so true. And even it just made me think how some communities may not have a specific word for suicide because you just don't talk about it. And so people might say things instead like, I feel tired, or I'm sad, or I'm hopeless, but not actually saying the word because it may not be part of common conversation. So I like your point there, definitely, to consider cultural aspects.
An interesting fact, as maybe we can end on this as an open-ended thing. So when I was doing some reading, the Public Health Agency of Canada said that immigrants to Canada were 3 times less likely to die by suicide than a Canadian-born population. So that's maybe counterintuitive to what I would have thought when I was reading the stats. So it might be interesting to dig a little bit deeper and see why that's the case. What are those protective factors, or how are those risk factors different in causing these disparities that you didn't expect?
Well, suicide is a difficult subject to talk about. We've seen in this episode that investing in suicide prevention can save lives. We've explored the different aspects of prevention and also suggested a shift to a more holistic, rather than individual, model of prevention. We hope that this episode will be a starting point for more conversation and sustained action towards preventing suicide.
Thank you for listening to the Public Health Insight Podcast, your go-to space for informative conversations, inspiring community action. If you enjoy our content and would like to stay up to date, follow us on Instagram, Facebook, Twitter, and LinkedIn. To learn more about our community initiatives and how you can support us, visit our website at thepublichealthinsight.com. Join the PHI community, and let's make public health viral.